Okay, which stars Bryan, Sturgill, and myself. So we're going to talk now about methamphetamine use in Washington State, and we're going to be blending data and first-person perspectives. So this will be myself and Bryan, who will introduce himself in just a moment. So we can have the next slide. So we're going to discuss background information and data. That'll be me, and Bryan will be providing real-world context. And we're really going to talk about how and why people are using methamphetamine, what's in the methamphetamine, and then break down a little bit of this idea around overamping and mortality, or this idea of overdose, and talk about implications for services and supports. And I do want to pause here for a moment. If Bryan wants to come off camera and unmute, I'd love for Bryan to introduce himself.
What?
We can hear you. Okay, Bryan, do you mind introducing yourself?
Can you hear me?
Yes.
Yeah, I don't know what just happened. I just lost my video, but I went to unmute and do that, and it clicked me out of there. So anyway, my name is Bryan Sturgill, and I represent Gather Community Services and Meds First. It's a medically assisted treatment center. I have almost 2 decades addicted to methamphetamine. And now I share my experience and lived experience helping others in overcoming obstacles and getting back on track and starting a new life free of methamphetamine.
Great. Thanks, Bryan. And really excited. I've been working with Bryan for several weeks on his presentation, and he's bringing a lot of really important insights into this work. And so we will dig into this, and I will give you any cues if you need them, Bryan. So we'll be good here. So if we can get the next slide, please. So why are we seeing more impacts around methamphetamine? On the supply side, we have really high availability and low cost. And I will note, as I mentioned, I've done work in this even starting 30 years ago, and prior to that, methamphetamine has long been really endemic or very commonly available across Washington State. And we continue to have high availability and low cost. The difference is 30, 20 years ago, we were looking at locally manufactured methamphetamine, and we're now generally looking at methamphetamine that's coming up from Mexico that's pretty consistently high purity, at least when it comes in, and very, very low cost. I mean, I just hear from everybody, whether it's housing providers or anywhere else, that methamphetamine is everywhere and just incredibly inexpensive. On the demand side, many of the reasons that people use methamphetamine have increased in recent years. Methamphetamine is you'll hear later today, is a stimulant, it's a mood enhancer, it's an appetite suppressant, it has a lot of benefits for some people in certain circumstances. And so it can really be helping people function in multiple different ways, including multiple jobs or multiple demands in their life, whether they're running a household full of kids or having multiple jobs or working a swing shift. There's a lot of reasons people use stimulants, and one of those stimulants is methamphetamine. A lack of housing. And people are like, well, how is that related to this? Well, there's a lot of different things, but among them, one of the things we hear oftentimes, particularly for folks who are unhoused, is a real threat to their safety at night, and it's important for them to be vigilant and to be able to be awake and be able to protect themselves, and maybe even just to walk all night. So it can be really relevant in that context. Untreated mental health. Stimulants are a very strong mood enhancer. And in fact, we use some types of stimulants to treat attention deficit hyperactivity disorder. And trauma as well. Methamphetamine, along with many other substances, allows people to sort of feel good and or to not feel. And so this idea being a way to have a break from the feeling of trauma that folks have is a really important reason to understand that folks may be using stimulants and methamphetamine. And then just generally lack of jobs and poverty. And it can even be sometimes boredom or just sort of triggering all these other things that are happening above. And so in summary, there's a lot of meth out there, and there's a lot of reasons that people use meth. So Bryan, I don't know if you can see this slide, hopefully, or you've got these slides around meth dependency, it'd be great if you could speak to this.
Okay, there I am.
Great.
Hello, meth dependency is like being stuck between The stress of being on meth, with that comes guilt and shame, erratic behavior, showing up late to work, just not showing up, a lack of productivity and motivation, um, legal parenting issues, uh, CPS, family issues, psychosis, loss of meaningful relationships, physical and mental health issues, and hypersexuality. So that's the stress of being on meth. And the stress of not being on meth, massive anxiety, hopelessness, lethargy. Um, when I was kicking meth, it seemed as if, weeks would go by where it was just between the bed and the shower, you know, and life just kind of stopped. I didn't want to go back to what I was doing before, but if it was going to stay like this, I couldn't see the end in sight. Um, so along with that, inability to feel pleasure or motivation, post-acute withdrawal syndrome, weight gain. Um, but it's important to remember that these are temporary and improve over time, especially with supports. I wanted to say between the couch and the refrigerator, like I was talking about, or the bed and the refrigerator, I was very fortunate to have a refrigerator and a bed. So imagine being homeless and you've got to make it across town, and you're feeling that way for a week or longer. Even though you don't want to go back to the stress of being on meth, it looks pretty tempting just to function. So these are the struggles, and I think this is also why it's so important to meet people's basic needs. Transportation, food, a place to chill out. These things are so important as motivators.
Great, thank you. I really appreciate that. I think that gives a good feel for what it's like, and I really appreciate you sharing that. So I'm going to talk a little bit about some data, and then Bryan will come in and talk a little bit more about what it really means. These are just some data, and these are all available on our webpage. This is from the 2023 Washington State Syringe Services Program Participant Health Survey. This is something we are doing in collaboration with several dozen harm reduction programs across Washington State, many of whom are here, and we are just incredibly thankful for their collaboration and all of this work. What I think is important to look at, there's a very high proportion of folks who use both meth and fentanyl. So on the right side, if you look at this graph, in the upper right, you see this horizontal bar. And what that's showing on the left side in pink is that 35% of the respondents to the survey said they only use stimulants. 7% said they only used opioids, but the majority used opioids and stimulants. And what does that mean? So we unpack that a little bit. And if you look at the pie chart in the lower left, this is among people who said their main drug was fentanyl. So among those who said their main drug was fentanyl, 88% of people use stimulants. So the vast majority use stimulants. Conversely, those who said their main drug was methamphetamine, just a quarter of those folks used opioids. And I think that's important to understand. I'm going to ask Bryan to sort of talk a little bit about sort of why we see some of these different patterns.
Yes, why and how they're used together varies. Those on fentanyl may use meth to get stuff done. Um, I've also heard and experienced that they hope it'll prevent an OD. Some people might take meth before using fentanyl, especially if they're not supervised. And conversely, those on meth may use fentanyl to sleep or come down.
Great, thank you. So I think it's important to understand that we often have this broad category of, oh, polydrug use or multiple substances, but there's different things going on in there around these patterns, and there's different motivations. And as we're thinking about our solutions at sort of the systems level or with the human being in front of us, understanding how and why these might use these drugs together is super important for thinking about how we can support their health and safety. So just a little bit, and please take a look at our webpage for a lot more. So this is, we're really fortunate to partner with the Washington State Healthcare Authority and Department of Health and many harm reduction programs across Washington State for what we call a community drug checking network. And you can see this online, some of this information. This is basically where people bring in a small bit of residue of their drugs and are able to get some testing done on site and then to get additional testing done at a lab out of state where we get really detailed chemistry. And these are some of the results of that. And just at a very high level, what we're seeing is the fentanyl supply is highly variable and changes quickly. In the graph in the lower right, don't worry about trying to read it. What I want you to see is the lines are bouncing around a lot. And what these lines represent is what substances are in drugs that were sold as fentanyl over the last year in Washington state. And these data are broken down by quarter, and you can see how quickly things are changing. For instance, that black line that came out of nowhere was an industrial chemical called BTMPS. It came from nowhere to being in a third of drugs in just a half year. So a stunning change. The red line was no fentanyl type drug was present. That we saw a lot of that a year ago, and now we rarely see that. There's usually some type of fentanyl product. May not be fentanyl, might be something weaker or stronger or multiple substances. The green line is something called xylazine or tranq you might have heard of. We see that in about 8% of samples, but that varies. And it's also very different than on the East Coast, where that's a much more common substance. And now there's another substance relatedly called metonidine, which is coming in, which has some really similar properties. And then the last thing, that little blue line, is talking about strong fentanyl products, things like carfentanil. Those sort of came in during a period of weak fentanyl and then disappeared. The takeaway here is that you don't know what's in the fentanyl, and things are changing really quickly. So we encourage people to take a look at the drug checking webpage. On the flip side, and I'm not showing the data, but I'll just mention it, when we look at methamphetamine, 98, 99% of the time, if something is sold as fentanyl, sorry, I apologize. When something is sold as methamphetamine, 98, 99% of the time, it is methamphetamine and not much else. We don't know what the purity is. We know that it comes in at very high purity. It may be sort of cut with more inert things, but generally the methamphetamine is methamphetamine. But where people run into particular trouble is if they don't know what it is. If it's a white powder or crystal, it could be fentanyl or methamphetamine. You simply can't tell by looking at it, smelling it, tasting it, any of those things. So just want to share a little bit about what's in that drug supply. Really high level here. This is looking at drug-caused deaths or poisonings. These were data that were originally put together by Washington State Department of Health, and then we do some work particularly to draw out specifically the methamphetamine-involved deaths. The black line is the overdose rate across Washington State for any drug being on board, and many overdoses have multiple drugs, so I'll just note that. So what you can see here is a huge increase over the last few years in the overdose death rate, just tremendous. Even as things ebbed and flowed for 15 years with, is it pharmaceutical opioids or heroin or fentanyl or methamphetamine or cocaine, the overall overdose death rate stayed pretty similar. Where things really started to change was about 6 years ago. That red line increasing opioids is really fentanyl, but you can see methamphetamine actually started increasing previously to that. And those are intertwined, and I'll come back to that in just a moment. I do want to note this is really important. This is looking at deaths involving psychostimulants. This is almost all methamphetamine involved overdoses or fatalities. And the top line here, really stunningly and really tragically, are our American Indian Alaska Native neighbors. And you can see just a grossly disproportionately elevated rate among overdoses involving methamphetamine. We also see this for fentanyl as well. And then next most line is the purple line here among African American Black citizens of our state. Hugely elevated overdose rates among those populations. And that's something we really need to be mindful of as we think about where and how we make our services available, both in place, but also in terms of culture and community and relationships and who's involved in providing those services. Okay. This slide is going to take a little bit of unpacking, but I hope you'll stick with me because it's really important to the conversation today. So this is, again, these things that are called, they're termed poisonings or overdoses. The left slide here with the shading is really looking at, these are methamphetamine involved overdoses, and the section with the orange shading is methamphetamine plus opioids. Back in 2014, that was a slight minority of deaths involved methamphetamine and opioids. Those have increased tremendously and are now the majority of overdose deaths. The blue shading are deaths that involve methamphetamine and no other strong psychostimulant drugs, no other strong, drugs. And so what you see there is that those were the majority of deaths. They're now actually a bit of a minority, but we've also seen a large increase in those deaths that involve methamphetamine only. Specifically, last year in Washington State, there were 1,934 methamphetamine involved deaths. That's an enormous number and an enormous rate. And more than a quarter of them had no other drug present. So, in looking at this and thinking about what can we learn from this information, these mortality data are really tragic to see. Are there any lessons kind of learned or information we can glean from this? And I was really kind of struck by this continually large proportion of folks who are methamphetamine only deaths, and that those have also increased. So we dug into that a lot. I have a wonderful colleague, Jason Williams, who dug into these data. And now I'm going to look at the graph on the right. And what the graph on the right is showing is the median age at the time of death for methamphetamine involved poisonings. So back in 2010, you can see really similar kind of mid 40s, both for the orange line, which is meth plus other drugs, and a blue line, which is methamphetamine by itself. But those lines began to separate over time. And specifically, those deaths involving methamphetamine alone, the age has consistently been increasing over the last 15 years or so, to the point where last year, the median, or essentially median average age of folks who died from a methamphetamine death by itself was 56 versus 44 for meth plus other drugs. And the meth plus other drugs didn't really change much. So what that suggests to me, I can't prove it, but it does suggest that those folks have definitely gotten older, and they're much older than those with methamphetamine plus other drugs. And I'll talk on the next slide a little bit about what that means in the so what relative to today's conversation. So fentanyl has driven the increase in deaths for sure, but we've also seen a large increase in methamphetamine involved deaths. And there's something about this methamphetamine involved deaths that seem different than the meth plus opioid or other drug deaths. And I'll note we've done some other work, both our colleagues in San Francisco as well as here in King County with the medical examiner. Deaths that involve methamphetamine and opioids, there are a lot of things biologically and around the cause of death that really look like those are really primarily driven by opioids. The meth is present, it's not helping for sure in that situation, but they're really more they're really more opioid or fentanyl related overdose deaths. But what we're seeing here is this median age has been increasing. There's two things I think that are underlying that. One is this idea about sort of an aging cohort of folks. As Bryan mentioned, he used methamphetamine for 2 decades. That's not uncommon, that people have this long period of use. But we know that methamphetamine has very serious impacts on multiple organ systems in the body, including the heart, and in particular the heart, where we see fairly young people with advanced cardiovascular disease and enlarged hearts. And so this particularly cardiovascular effects we think may be related to this cohort effect and this older population of folks. And what that means is that these deaths often it may be less about what happened the day of the death, the methamphetamine that was used. And we often see them in those meth-involved overdoses that the meth was used many, many hours before. It's not like an acute or sudden overdose or too much of the drug. It seems like it's often more the cumulative effects of those drugs that are catching up with folks. So I want to hand it over to Bryan to talk about sort of, as he and I were talking about this, he really shared some really important insights and thoughts about what healthcare providers, how they could have maybe more productive conversations. So Bryan, if you could tell us a bit about that, I appreciate it.
Yeah, what healthcare providers could share. I know most of the time when I would go into the emergency room or urgent care or what have you, uh, I, I, I would probably be overamped, not communicating properly, not really understanding what was going on. And um, if somebody told me that I had 200 over whatever blood pressure, those are numbers. I don't understand what that means. And compared to what could actually happen? Could I have a stroke? That would be helpful to understand. I mean, I don't am I high risk or low risk? Is this going to affect me right now if I don't change my behaviors? Um, uh, Another example would be cellulitis. What does that mean? What's happening to the tissue in my legs? What else could happen if left untreated or not reducing injection or drug use? Blood clots, MRSA. I would know that I would go in not feeling well. They would throw some numbers at me oftentimes. I knew that I was getting an IV bag of something, and then I'm good to go. You know, And so what are the possible outcomes could be very, very useful information.
Great.
More information would be useful information and context. I think I've really only had I'm holding a memory of a doctor actually telling me what was happening to me, what I was doing to myself. Um, so yeah.
Great.
Conversations could potentially motivate change if the person fully understands the causes and consequences in a nutshell. I would ask that healthcare providers don't give up just because you don't see immediate change. I don't need you to scare me, but I do need good information that I can understand.
Great. Thank you. And I hope we are also providing that today, and maybe that'll be a good model both for folks to know how to ask those questions. Hopefully, some of our healthcare provider folks and their care teams to be able to be a little more practical and useful in real time. So thank you for that. So next, so this, I just want to note that these things exist. We have an amazing team of folks who you can't see behind the scenes right now, and other folks here at our center who do really wonderful work. And so we're really fortunate to have people who use drugs share their expertise and insights via the surveys that I've mentioned, and also via qualitative interviews. And so these are a couple of our brochures that are available. Really nice work that was done by Allison Newman and a student CRT, looking at understanding the perspectives of people who use methamphetamine around their interest or not of reducing or stopping their use sooner or later. So I really encourage people to take a look at that. And then some more recent work by several folks on our team, led by Teresa Winstead and some other colleagues, really looking, trying to understand more about ideal care for folks who use fentanyl. So I encourage people to take a look at that. And then we also have done some really nice work led by a wonderful social work student, Saul Petersky, really doing some work around people in permanent supportive housing. Such an important population of folks uh, who are often continuing to use substances and really running into some both health and social consequences of that. And some really nice insights in this work about, guess what? Folks do want services. They do want safe environments. And also the staff there feel like they need more tools as well. So I encourage people to take a look at some of these resources. And I'm going to share in the next couple of slides a couple of the big takeaways from some of this work we've done over the last several years. So implications for care. So this idea of shared decision-making with ongoing engagement and care navigation may provide the foundation for long-term caring relationships. I, I think one of the strongest tools we have is relationships, really providing the foundations and the glue upon which you can layer all the other things we're going to hear about today. Part of that also is how do we access care? Creating drop-in access to comprehensive services over an extended period of time is something we're really seeing beginning to blossom across Washington State in particular, as well as in several other cities as well. And the idea that harm reduction, treatment, and healthcare are all available, ideally on site, and whatever a person needs that day. So, Bryan, can you just say a little bit briefly about sort of Gather's low-barrier buprenorphine program?
Yeah, here at Gather Community Services, we have a low barrier butte program, Vivitrol, Brixadi, um, providers, nurses on staff, substance use, dependents, outpatient groups. Importantly, we have care navigators and care coordinators that make reminder calls and follow-up calls when someone misses an appointment. Attendance isn't perfect, but ongoing engagement rates are very high, and I have a little bit of that right here. In other words, if somebody missed a scheduled appointment, they usually came in within 7 days after missing one, or 7 days within their appointment date. And that number is well over 80%. So while some appointments were rescheduled by client in advance, many were the result of follow-up calls. So.
Great, good. Thank you. Appreciate that example. Super helpful. And if you maybe talk a little bit more for sort of from your perspective about what the implications for care are, that'd be awesome.
The implications for care, heart health and primary care are very important, which can be challenging for marginalized people in the midst of meth use. When trying to get care, you may not present how you want. Like I was saying before, if you're overamped, you come in with the intention of getting some questions answered or maybe an appointment scheduled, but you're not presenting well, you're not able to verbalize those sorts of things. You may need a space to just chill out. Um, and you may need a staff that's understanding of the condition that you're in that allows you a place to chill out. Maybe some food, get your thoughts together, feel supported. Harm reduction is an entry point, and ongoing services are critical given the diverse pathways to health and recovery. I already spoke on that.
Okay, great. Thank you.
Yep.
So next slide. Great. So to sort of wrap up the presentation piece, and we'll move into Q&A in a moment. And please do put any questions into the Q&A section. We'll see those most easily. So how and why people use methamphetamine differs in many ways from opioids. And I mention that because there's so much work and talk and attempted changes in practice related to opioids. Some of those benefit and serve folks who are using stimulants in addition to opioids, and some don't. And so we really need to think about how to match these differences. And so you'll hear about that today, and I encourage you to think about, like, how is our current care model working, and how might we need to adjust it a bit to really be inviting and accommodating of folks who are using stimulants. So again, those initial care services and those access points may look different at the community level. Where are people going? Where are they being engaged? I am a strong believer in bringing services to where people already are, where they're instead of expecting them to somehow navigate our incredibly complicated and burdensome care systems, and then blame them for not showing up and presenting at all or on time. And I do want to acknowledge this. There can be challenges integrating harm reduction, treatment, and healthcare. We've been doing a lot of work, and I saw we had somebody from New York on the line and heard a lot from our colleagues in New York at a recent conference. I mean, there are challenges with bringing sort of harm reduction into treatment and healthcare, and there's challenges with bringing treatment and healthcare into harm reduction. But I really encourage people to be open to those conversations and figure out how they can provide those access points and the right service mix in their community. There's no one size fits all by any chance, by any means, and we have a lot of resources on our webpage as well that I hope people will take advantage of. And bottom line, this is really going to take a broad array of people working in different types of care settings with different populations, with the different tools, whether it's healthcare or SUD treatment or our tribal colleagues or harm reduction or housing or DCYF, all of these different folks really working together, ideally with some common language, some common goals, some respect for each other's approaches to our work, so we can really be of service in a coordinated way for folks who are using stimulants. They need that and they deserve that. And I'm so heartened to see everybody that's here today who I know are coming from these perspectives and excited about this work. So that's you, and we're glad you're here. And I would love to see we have a couple of questions. Please keep putting them in there, and we will move into the Q&A section. So let's see. There was a previous question I'll just mention. We already answered two of them. One was around what is cocaine looking like in this context. We are actually seeing a bit of increases in cocaine recently. Cocaine is a different drug. It is a stimulant for sure, but it's a different drug than methamphetamine. In particular, generally people use methamphetamine more frequently, more days out of last month, and for longer periods of time, and it has much longer lasting impacts on the body. So there are definitely some differences for sure in cocaine. Some of the treatments we'll be talking about today, some of the interventions we'll be talking about today, definitely the care models are really similar in terms of how we want to create our care settings and how we want to engage folks. So I want to note that. There was also a note in there around skilled nursing facilities and real challenges in those types of care settings in terms of caring for people who are using substances. And we definitely see that. Was from a colleague in New York. We definitely see that in Washington State. And that is a real challenge. And I think that is part of what I hope people will come out of today is please share this information with your colleagues. If you have a friend who works in a skilled nursing facility, please share this with them. If you have a friend who's a dentist, dental care is super important for folks who are using stimulants. Are the dentists really prepared to work with folks who are actively using methamphetamine? Please reach out to them and engage them, both in education, but also hopefully ongoing relationships and conversation. I see there's a question there. I'll answer briefly, and I definitely want to hand this over to Bryan. So, the question was about the permanent supportive housing survey. Can you speak on how those surveys were collected? I'll just share very briefly. Please take a look at those. Saul is an amazing person and gives a lot of great detail on that. Saul did incredible legwork. Went to, I believe, almost all of the 13 permanent supportive housing programs across Washington State. Did in-person surveys. This was our very first time working in this setting. I learned a lot. I learned a lot from Saul. Saul learned a lot. Very different than doing surveying and harm reduction programs. We will definitely, hopefully, be continuing to do that work. This is what I would call more of a convenient sample. At the harm reduction programs, we really are able to try to make the surveying available to everywhere. Within the permanent supportive housing programs, that was a little tougher, depending on the care model and the time of day and who is present, and also learning that folks like, the folks who are using opioids may be less likely out and about, which is where we were surveying, versus folks who are using stimulants. So that's a little bit about that. And then the question around, I'm sorry, I got a bunch of data questions, Bryan. I'll hand some over to you. Around methamphetamine related death, do we know how many were unhoused? That's a actually surprisingly tough question to answer. I know the King County data better, and what I will say is that we definitely see in overdose deaths that there's a gross disproportionality. People who are unhoused are much more likely to die of an overdose than the general population, as are those in supportive housing programs as well. Those are folks who actually end up often using alone and are still at sort of excess risk for overdose. Is there anything else you would say sort of about, what you're seeing around the dynamics around particularly maybe overdose risk for folks who are unhoused, Bryan?
Oh, it just creates massive barriers for support. Um,
Okay.
yeah, everything that goes along with it.
Okay.
Yeah.
Great. So Cami asked about where are we at having MAT available for individuals dealing with methamphetamine withdrawal? And I'm going to save that question for my colleague, Dr. Jonathan Buchholz, who's going to speak later because he is an expert physician in this area. So I'm gonna punt on that question to Dr. Buchholz. Um, and then you mentioned bringing care to where people are actually physically at. Are there any best practices for doing this with a transitory population, such as those who are unhoused? Bryan, can you maybe speak a little bit about what Gather does in terms of trying to connect with folks who are unhoused?
Again, the out boy, that would be a question for my employer.
Okay.
And I really don't want to speak to that.
Okay.
I know that there is a massive need for people, especially with rural communities. A lot of people don't have transportation. I know that the bus routes only run so far. Our care navigators and care coordinators do the best we can about providing transportation to appointments and providing drop-in spots for them. I mean, if somebody shows up and they're at the stage of change where they're willing to make a change and get some questions answered and go for that. Of course, you want to accommodate them. So bringing that to them, I think, is crucial
Okay.
wherever they are.
Thank you. And I'll mention to David's question, some maybe obvious things, but I do want to state them because we have a really diverse audience. Certainly the ability to actually do outreach, to go to where people are is really important. And to have that outreach, it may be that it's outreach and then you're providing transportation back to other services, but we're also seeing folks, and it's a lot of work to stand this up, but if you can bring the care along with that outreach, if you can have a medical provider either on site or maybe even virtually, and then get medications, whether if it's treatment medications or wound care medications, that can be super important. So really trying to figure out how to get the care to people. And then on the flip side, I think it's important, and we'll talk more about this later. Also, inviting reasons for people to come in who may be unhoused. And that may be really basic needs, right? That might be socks and food and water. And that may sound obvious, but those are really important things that people need. You'll hear that more later about how important good physical hygiene and things like clean socks are super important for folks who are unhoused, as well as things like food and water. I just can't say enough about how important it is to have some nutrition, hopefully good nutrition, as well as hydration are actually really, really important for health and well-being. Um, okay. So Lorna Johnson, great to hear and see from you, Lorna, from the northwest tip of beautiful Washington State. Great to see you. I live in a very rural area. We've attempted to DCR, that's a designated crisis responder, a few people using math. We lack services for these people and would need help setting up a DCR system for our rural tribal population or location. That makes a lot of sense. And these people have been experiencing meth, including psychosis, long term, and we do not know how to help them. Totally hear you on that. And a couple of things I would mention. One, Dr. Buholtz will talk a bit about that. And we also have some really wonderful resources from another colleague, another addiction psychiatrist, Dr. Mark Duncan, as well as Dr. Buholtz, about psychosis and um, what that is, how it manifests, how it presents, how long it may last, trying to figure out is this methamphetamine? Is it psychosis? Is it both? So I don't have any simple answers. There aren't simple answers, but there are some nice resources that are available. And we also have some resources that'll be coming out very soon from another one of our products called Scala Northwest. Some things around there sort of geared kind of towards emergency departments, which in some ways, oftentimes, right, if you're in a rural community, some of your responses may not look unlike those that an emergency department may have to do with limited resources. So I'm sorry to punt on that a bit, Lorna. Super happy to follow up with you, but we also have some good resources online I would point you to. Bryan, I really want to hand Jackie's question over to you. How do we get buy-in from places like emergency departments and urgent care? How do we get, how might we best get a person to I don't know what the right term is, but I'll use the term engage, but maybe I should say feel comfortable and being honest. You know, how do you do that in your work?
Uh, by accompanying uh, by accompanying clients to their appointments, going along with them, supporting them, being that point of contact with that medical facility or that medical professional, so that I might be supportive and take notes, get releases of information going both ways, so that I can make sure that person makes it to their next appointment and understands what their continuing care looks like.
Yeah.
Um, Also, I think that I think it really helps. I
Yeah.
really, I really do. I think it
And
helps the client, and it also helps the medical professional to understand what the situation is and buy in. Yeah.
yeah, and that's super practical. I hope people really hear that. I can't say enough about that, where the way they can help somebody in that situation is in some ways kind of be an ambassador and a support person. So that you're helping a healthcare provider understand what's going on, and you're helping the person who's there for care understand this really complicated system and anything you can do to sort of facilitate that and take off that stress or concern or anxiety that's like, I just don't feel good and I need help and I don't know how to translate that into the words that will give me the care I need. And so what I'm hearing you say, Bryan, is that that's something that somebody can really be really helpful with in that process.
Yes.
Great, thank you. Um, a question here about high school setting. How do we get more information directly related to that population? I don't know that we have information directly for that population around stimulants. We do have some information that we've just put out recently around supporting the health and safety of youth who are using fentanyl that I think is relevant. You'll see some things later around sort of a two-pager that we've put together as sort of a health support guide for folks who use methamphetamine that is really relevant for that, Bruce. I think those same things are directly relevant for youth as well. Probably what stands out a bit more for youth is they're likely to be more naive and more likely to be getting some substance from another person. And so that's really where the sort of, well, my friend told me this is cocaine, it's a white powder. That's a red alert type of a thing. And for them to really understand the real hazards that might be present. We just have time for a couple more questions. I love these questions. Thank you. And what are the treatment options for patients who are taking methadone for their opioid use? So, great question. What I would say, and I know Bryan's working more in a methadone in a context where buprenorphine is used versus methadone, but it's really the same thing. Essentially, if a person's using methadone or buprenorphine, as you'll hear later, just using those and staying on those medications for opioid use disorder, many people, their stimulant use goes down. But as you'll hear later, we're going to talk a lot about that. This is a lot of what you're going to hear today is what else can we do for those folks? So that'll be something we'll come back to pretty quickly. And there any study that compares success rates between harm reduction and complete abstinence? That is a great question. And I think I'm going to answer that with a response that may sound a little bit strange, but I think it's important. One form of harm reduction is abstinence. These are not things that are in conflict with each other. It is harm reduction to use less. It's harm reduction to use none. So I think that's a super important perspective to look at. And so this idea about a rigorous study comparing these two things is something that would be, as a researcher, a very difficult thing to construct. And what I think is actually important is to recognize those things are really not in conflict with each other. And the last question from Cami, how is Washington State addressing the ongoing challenges with medical providers still carrying a stigma mindset for individuals dealing with addiction and or co-occurring issues? In a lot of ways, one of the ways that we're really fortunate to do it out of our center is we provide regular trainings as part of our work supporting the state opioid response. We have a wonderful colleague who's a care navigation expert and really speaks to stigma a lot, Leilani Dawn, and they can really help speak to that. So I encourage you, people are very welcome to join those monthly trainings. And very recently, hopefully can put this in a list of links in a moment, Leilani has just put together a series of 3 brief videos to really get at stigma. And I think that's so important. And I hope people will take that information not just into their care with people who are using drugs, but also in turn to think about how they can use that information to look upstream and reach out to their fellow care providers around how they can how they can also maybe rethink how they're treating folks. So we'll stop there with the Q&A section, and we will take a 5-minute break, and I encourage people to come back at 10. So thank you so much, Bryan. I really appreciate that, and I appreciate
Thank
all the
you,
great
Caleb.
questions, and we'll be back in just a few minutes.